I think that at the end of my discussion, you should be able to see pretty clearly why I'm really enthusiastic about the Paleolithic diet as a means of preventing kidney disease, if we can get to people early enough. And the reason for that, and really the main reason, is that if you talk about what causes kidney disease in the United States and Western Europe, okay, kidney disease is a vascular disease in people who have diabetes, high blood pressure, and atherosclerotic vascular disease, so people who are obese, okay? And what have we been talking about today except diets that affect people who are diabetic, hypertensive, and overweight? So, and right now, if we're trying to control diabetes using an ADA diet, we're only minimally successful. We have about the same luck with high blood pressure, and the obesity epidemic is getting worse. So if you look at all those factors, you would say, you know, what's going to happen to people's kidneys? And you would expect them to just keep getting worse and worse. And there's some data that suggests that, in fact, kidney disease is becoming a lot more prevalent. Huh. Well, we could do it that way. I'm not going to say no, but perhaps we'd like them large size. Doesn't look that way on the screen, does it?
Nice.
Okay, so this is what I just said. You can see that over the course of the last 20 years, the United States is getting fatter and fatter and progressively more diabetic. And if you look at the NHANES database, you can see that people who have diabetes and people who have high blood pressure and people who have heart disease, which is also a vascular disease, tend to have kidney disease. And this isn't even a little bit surprising, because if your blood vessels are in such bad shape that it's affecting your kidneys, it's not surprising that it's affecting your heart and your brain and the blood vessels in your legs too. So what we see is people who are total body vasculopaths. The blood vessels in their bodies are very damaged to all of their organs. And because I'm a kidney doctor, I happen to see the ones who have kidney disease. And I put this slide in here to say that although I'm going to be talking about diet, you should recognize that there is in fact a genetic component to high blood pressure and kidney disease. And this is particularly apparent in African Americans, who we now believe have a tendency to have an allele called ApoL1, or for A-beta lipoprotein 1, which protects you against trypanosomal infections and the fatal disease African sleeping sickness. And the more alleles you have for this, the more likely you are to develop something called focal and segmental glomerulosclerosis, which leads to progressive kidney failure in and of itself. And then if on top of that you're diabetic and hypertensive and overweight, you're even more likely to develop kidney disease. And this is what we've been saying all along, that 75% of the calories in Western diets, especially American diets, tends to be junk food, dairy products, and cereal grains. And so what we did in our studies, this is a study where in well-controlled type 2 diabetics, We put them on either a Paleolithic diet or an American Diabetes Association diet. We took the calories from dairy products and cereals, and we just gave them those calories as fruits and vegetables. And as Malin was saying, it was very difficult to get the people to eat all the food, because when you actually looked at it, it was so much food. And we broke it up into 6 meals a day. So breakfast, mid-morning snack, lunch, mid-afternoon snack, dinner, before bedtime snack. And even then they complained about how much food they had. And if they started to lose weight, we fed them even more. So now they had to stuff themselves even more. So it was hard to keep them from losing weight on the Paleolithic diet. So you can see that, both groups improved, because as I said before, I think our patients were just eating really bad diets. But in the Paleolithic diet arm, okay, what you see here, we did euglycemic hyperinsulinemic clamps, which is a measure to try to decide how much insulin you need in order to be able to keep your glucose levels the same. And the lower the M number is, the worse you are. And so what you see here in the paleo diet arm is that the ones who had the really low M values were the ones whose M values improved the most. And so if I had to say to myself, who would I want to concentrate on? This over here, this is the group that needs the help. Those are the people who are in really bad shape. The ones whose M values are up here, in fact, like this patient over here, really, she was really good to begin with. That's not the person that I would be, would try to put all my energy into trying to take care of. You've seen this before. Again, this is Tommy's study, and basically shows that you can improve diabetes control. We did it in a short term by feeding people. They did it in a slightly longer term by telling people what to eat. And then he's talked about the 2-year study where, again, they told people what to do. Now, we did not feed a low-carb diet. Okay, our diets were about 40-something, almost 50% carbohydrate. It's just that the carbs came from fruits and vegetables. But if you say that across the planet there are, could be hunter-gatherers who are going to eat a relatively low carbohydrate diet, then I think you have to consider low-carb diets to be part of the Paleolithic diet family. And it's pretty clear that low carbohydrate diets are really good at doing some things. Multiple studies have shown that they do in fact help you lose weight, that they make your hemoglobin A1Cs and glucose go down, and that they improve triglycerides. And the low carb people that I talk to are particularly vehement that we should, for people who have diabetes, we should really be telling them to eat a low-carb diet. What are we doing? Feeding them a high-carbohydrate diet if the problem is that they have all this sugar in their system. And of course, the carbohydrates that they're getting are carbohydrates from grains and dairy products. So in this study, this is a analysis of data from a study that was done called the DIRECT study. It was done in Israel between 2005 and 2007, published in the New England Journal. What they did was they compared a Mediterranean diet, a calorie-restricted Mediterranean diet, to a calorie-restricted low-fat diet, to a non-calorie restricted low-carb diet. And then they looked at weight loss over time. And then they reanalyzed their data, and they just published what happened to kidney function. And so this is the data that I'm showing now. So let's go through it. So after being adjusted for age, gender, use of ACE inhibitors, which affects kidney function, weight loss, which can affect kidney function, and protein intake, which can affect kidney function, we think. Okay? What they found was that people who, so let's look at the graph. So graph A, they looked at people with stage 3 kidney disease. So this is an estimated GFR between 30 and 60 milliliters per minute per 1.73 meters squared. So it went up in both groups. So this is stage 3, and this is stage 1 and 2, so greater than 60 with some protein in the urine. Over here, they looked at the same data except by diet. And you can see that it didn't matter what diet they were put on. Everybody's GFR improved. But when they looked at just the stage 1 and 2, there really wasn't much of a difference between the various diets, although they did have some improvement in GFR. But when they looked at stage 3, the low-carb diets got the best. The Mediterraneans, the little red spots are significant. The Mediterranean diet was not as good, but still significant, and the low-fat diet was not. And when they said, independent of diet, does diabetes make a difference? And the answer is yes. In fact, people who had diabetes got the most better, and that was independent of diet. So again, what I take from this is that diet is important, that some diets may work better than others, depending on the degree of kidney failure, and that people who have diabetes should be particularly inspired to go on diets in order to be able to try to help improve their kidney function. Now, that's what the data shows. In my experience, after 20 years of being a kidney doctor, it is incredibly difficult to get people to do any of these things. And that's where I think that if we can come up with something that maybe takes a little bit of all of these things. When I think of the Paleolithic diet, I think of, for example, it's like the Mediterranean diet in that we talk about eating, less saturated fat and more unsaturated fats. It's a little bit like the low-carb diet because we tell you to eat relatively low glycemic index carbs or get the carbs from fruits and vegetables. And it's a little bit like the DASH diet, which eats a lot of fruits and vegetables and also tells you to restrict the amount of sodium. And so if we took these items from these various diets and then put them all together into one diet, so that now we have a, quote, Paleolithic-like diet, so that maybe we could really come up with something that would really work well for people who have some degree of kidney disease from diabetes and high blood pressure, maybe we could really help them. Now I say some degree of kidney failure because you cannot put somebody with advanced kidney disease on these diets, okay? They cannot tolerate the potassium intake. And then there's a couple other problems too. But for people who still have relatively preserved kidney function, I think that this data is really encouraging. And now let's talk about how your kidneys haven't changed in millions of years, okay? So back when, okay, we were eating a diet which was particularly high in potassium and low in sodium, especially sodium chloride, okay? And a lot of the potassium in the diet is in the form of potassium alkali, like potassium citrate or potassium malate. And so your kidneys are particularly able to retain salt, and they cannot retain potassium. So you can reabsorb practically every molecule of salt that you eat, so that if you put out 1 liter of urine, you will put out 1 millimole of sodium. But in terms of potassium, you would put out between 10 and 15 millimoles of potassium because your kidneys cannot hold on to potassium because presumably in the environment that they evolved on, okay, it was a very low sodium chloride diet that was very rich in potassium. So your kidneys are still back in the Stone Age, even though our diet is not. And so that is really bad for you when you're in an environment where there's a lot of sodium chloride. So a colleague of mine, Curtis Morris, has been interested in this for quite some time. And What he looks at is not just what happens when you take sodium chloride, but what happens when you then add potassium or add potassium bicarbonate. And he believes that some people are sodium sensitive, some people are chloride sensitive, some people are potassium sensitive, some people are alkali sensitive, and that in the worst of all possible worlds, you would have your blood pressure go way up when you eat sodium chloride and not go down at all when you took potassium alkali. So in these rats, which SHR stands for spontaneously hypertensive rats, so they're genetically bred to develop high blood pressure, and after just a few months of life, they develop strokes and brain hemorrhages and things like that, and kidney failure. So what you see here is the rats over here are being given various amounts of either sodium chloride or sodium and potassium chloride, or sodium chloride with potassium bicarbonate, the little round ones over here. And after a few months, when you look at kidney function, you see the rats that were getting the sodium chloride, sodium bicarb, had much better kidney function compared to the other rats, especially the rats over here that were getting all that chloride. And chloride, for those of you who remember your physiology, increases the amount of renin, which then increases the amount of angiotensin, which then increases the amount of aldosterone, and raises your blood pressure and helps you retain sodium chloride while dumping potassium into the urine. So the rats that were given the high doses of chloride had these damaged kidneys after a couple of months. This is all scar tissue over here, and the glomeruli are all damaged, compared to the relatively normal kidneys over here of the rats who were given potassium bicarbonate with their sodium chloride. So far I've talked about diabetes, high blood pressure, and a little bit about vascular disease, because that's the things that we see the most. But there are potentially some other things which we're now starting to look at more, which may be particularly important in people who have or are prone to develop kidney disease. So we've talked about genetics a little bit. Now let's talk about whether or not your blood pressure goes up when you take salt. So some people are able to eat all the salt they want, and it doesn't do anything to their blood pressure. And then other people, when you increase their salt intake, their blood pressure goes way up. And the standard physiologic way of thinking about this is that as you retain more salt, you retain more water in order to be able to maintain your blood sodium levels at the normal range. And that because there's more fluid in your system, then the pressure in the vessels, in the blood vessel, goes up, especially if the blood vessels are not able to dilate adequately. So there's just smaller space, more fluid, higher pressure. And so people like this, so that's the old standard Guyton theory of fluid retention causing high blood pressure. But my colleague Curtis believes that there's another mechanism that salt can cause high blood pressure. And so what happens is in people who are salt sensitive, they have higher levels of something called asymmetric dimethylarginine. And this is an inhibitor of nitric oxide, and nitric oxide causes your blood vessels to dilate. So you have high levels of this, so your blood vessels are not dilating as much. And in addition, this also causes an increase in myeloperoxidase in the white cells, which cause the white cells to degranulate and start to damage the blood vessels over here. And at the same time, this also decreases this enzyme over here, which helps denature ADMA. So you get the you get the white cells and the myeloperoxidase over here damaging the blood vessels, and there's less of an ability to get rid of the ADMA, and this becomes a vicious cycle, so that, in fact, these people are damaging their blood vessels. And people who are salt sensitive, you can show that as you increase the amount of sodium in the diet from, say, 20 to 120 to 220 millimoles a day, what happens is when you do an oral glucose tolerance test, their insulin levels go up and their glucose levels go up. So something about being salt sensitive also tends to make you insulin resistant. And it works the other way around too, because it turns out that the more factors you have for metabolic syndrome, the more likely you are to be salt sensitive. So it's a question of which came first, the chicken or the egg. And I showed you this sort of very briefly before. So when we did our study and we were looking at the overall data, I was a little surprised the blood pressure didn't go down more than it did, because I've just told you that, we're taking away the sodium and we're giving these people tons of potassium, and so I would have thought we would have gotten a really terrific effect on blood pressure, similar to the DASH sodium diet. And there was a decrease, but it really wasn't what I expected it to be. So then what we did was we divided people into two groups. So the ones whose blood pressure either didn't change or went up when we put them on the diet, and then those whose blood pressures went down. And so you can see that actually we really had two different groups. One group whose blood pressure went down, this is mean arterial pressure, went down on average 8 millimeters of mercury, and the other group whose blood pressure on average went up 3 millimeters of mercury. And so what you see here is that the salt sodium people in both arms, tended to improve more than the salt resistant people in both arms. This was true for the insulin clamps that we did, it was true for glucose and fructosamine, and it was true for the lipid profiles. So I don't know why the lipid profiles would be affected. So if any of you have any ideas, I'd be interested in hearing that. Then, we've been talking about vascular disease. The worse the blood vessels are, the more clogged up they are, the harder it is to deliver oxygen to the tissues, and ischemia is a very big deal, especially in tissues that are poorly perfused. And oxygen is necessary for us to be able to efficiently produce energy inside the cells. So if you have hypoxic tissue where the oxygen levels are low, in order to be able to produce energy, the cell has alternative mechanisms, which both increase the amount of acid in the system, as well as increasing the amount of oxygen, reactive oxygen species. And it's pretty clear that both increased acid levels in the blood and increased oxidative stress in the blood have effects on the post-insulin receptor signaling, so that in muscle cells you start to get muscle breakdown, and in bones you start to decrease the activation of the cells that build up the bone, and you increase the activation of the cells that break down bone. You get less vasodilation in the heart, which is bad for your heart, and you get less glucose uptake into the fat and the muscle cells. And so if acid is bad for your kidneys, then the alternative might be true, which is that maybe alkali is good for your kidneys. And this was shown in some very small studies with advanced kidney disease, where they could slow the rate of progression onto dialysis by giving bicarbonate therapy, which then somebody at the University of Texas, Donald Wesson, then did a longer-term study where he gave bicarbonate to these people with mild kidney disease, and the solid line is the rate of decline of kidney function in the ones who are on the alkali therapy compared to the ones who are on placebo or the ones who are on sodium chloride. And what he showed is that the group that got the alkali therapy had the lowest aldosterone levels and the lowest endothelin levels. And both aldosterone and endothelin increase your blood pressure. So by giving alkali therapy, what they did was they helped prevent damage to the blood vessels, and this slowed the rate of progression of kidney disease, which means that if we're feeding a diet that's really high in fruits and vegetables, we should be feeding them a relatively high alkaline diet. And perhaps that would, in fact, over time, slow damage to the kidneys. And in fact, in our studies, the Paleolithic diet arm, the Paleolithic diet arm, but not the ADA arm, lowered the amount of acid that was in the body. And we expected that because I told you that we designed these diets. We thought they would be low in acid. So it turns out they were not as low in acid as we expected them to be, but they're definitely better than eating the ADA diet that we had people on. And this analysis from this French study where they followed like 67,000 women for 15 years, and then they looked at what happened, that the risk of developing type 2 diabetes depending on the diet acid load. So what it shows here is that at the low acid loads, their hazard risk was 1, whereas as they increased the amount of acid in their diet, their risk of developing type 2 diabetes went up. And now let's talk about the gut microbiome again, okay? So we have very few ways of preventing kidney disease. Control the blood pressure, control the diabetes. I haven't talked about it, but control the protein in the urine. And another way, which there started to be more information about this about 10 or 15 years ago, was control the amount of uremic toxins, which are developed by the bacteria in the colon and then absorbed into the system. And so there are many different types of uremic toxins. Just very generally speaking, a uremic toxin is something which accumulates in renal failure. And if you take it away, you can show that you prevent some kind of damage that the toxin is doing. And it's thought that the gut bacteria are in fact making a variety of uremic toxins. And so one of them is called indoxyl sulfate, IS. Okay? And so a Japanese company started making this sort of charcoal stuff called AST-120. And the idea was that it would adsorb the toxins in the gut so it wouldn't be absorbed into the system, and so these toxins wouldn't get in, and therefore they wouldn't cause kidney damage. And so you can see over here, here are the normal rats. Here are the rats who have had 5/6 nephrectomy, and you can see just by looking at it that these kidneys look a lot more damaged than these do over here. But when they gave the rats this AST-120, you can see that in fact the kidneys were relatively protected compared to the chronic renal failure rats that were not protected with the AST-120. Now they have since done 3 trials in humans. The first ones, which were small trials, were very promising. The second trial, which was much bigger, was not as promising. And the most recent trial, the results are not promising at all. But the idea that maybe we're doing something to alter what's happening in the gut, and that maybe somehow this is altering what's happening inside the body to the kidneys is an interesting one, and kind of goes along with the, like, what is the gut doing? What is the gut microbiome doing to the rest of what we're talking about with whatever we're talking about with gut microbiome? And then the other possibility is, these diets are very high in fiber, and we did a very small study. We were trying to decide, so our paleo diets were much higher in fructose than our ADA diets, and yet our glucose control was much better. And Rob Lustig, who's at my university, suggested that we try to figure out what was going on. And so we tried to look at hepatic glucose uptake and degradation. And we didn't see any difference between the people on the paleo diet and the ones on the ADA diet. And so my diabetology friends said, well, maybe it's the fiber in the diet, something about the fiber, you're not absorbing the sugars somehow, so the fact that the glucose control is better, even though the total amount of fructose in the diet is higher, like the sugar is just not being absorbed into the body. So this, sevelamer, is a fiber-like synthetic resin which we use in kidney failure as a phosphate binder. But what they did here, and this is a really terrific experiment, was they gave it not as a phosphate binder, but as an inflammation binder. Okay, I don't know what. Sorry.
I think when you turn into it, you're feedback.
All right, let's try this. And so what happened was after, let's see, this is 8 weeks in these people who had diabetes, and I think they had like stage 3 CKD. You can see that lipid profiles and glucose went down, okay? AGEs went down. The oxidant levels went down and the antioxidant levels went up. Compared to, they used calcium carbonate, which is another phosphate binder. So it wasn't that it was the phosphate binders doing something, it was something about the sevelamer that was doing something. And so if sevelamer is acting like fiber does, okay, it's interesting to, to think about whether or not we're getting some of the effects that we could potentially be getting simply because we're feeding people a very high fiber diet. Okay, so to review then, vascular disease. When we talk about kidney disease, we talk about vascular disease. I believe that the paleo diet can potentially combine all the really good things about the various other types of diets that people use, and that perhaps some of the things that are on top of, the blood sugar control and the blood pressure control, perhaps there are some very specific things about avoiding uremic toxins, trying to do things specifically for people who are salt sensitive, and lowering the level of both acidotic and oxidative stress. And that together, if we put all these things together and we fed these to people whose GFRs are still good enough that we can give them these kinds of diets, that potentially we could help slow down the progression of kidney disease. Because kidney disease is really expensive, okay? In the United States, it costs more than $85,000 a year to dialyze somebody. And that's the dialysis alone, not anything like the procedures or anything that they need in order to get the dialysis. And transplantation, really, the number of people on the transplant list is going up, and the number of transplants that we do every year is pretty much stable. So really, we just have more and more and more people who are on dialysis, and dialysis is really expensive. So if we can do something to slow the progression of kidney disease, we are really helping to keep people better. So anyway, thank you.